Hello, welcome to part 2 of the Antepartum and Intrapartum Care of Pregnant People with HIV series. This brief section will focus on the intrapartum care of pregnant people with HIV. My name is Lynn Yee, and I'm an associate professor of obstetrics and gynecology at Northwestern University and the medical director of our women's HIV program at Northwestern Memorial Hospital. In the next few slides, we will talk about the prevention of HIV transmission to the fetus during the intrapartum setting, as well as optimization of maternal care in this context. But first, I want to emphasize that rapid HIV testing on labor and delivery remains an opportunity, the last opportunity before birth, to identify pregnant people with HIV, and that a person with unknown HIV status at labor should be recommended to receive rapid HIV testing. For those listening to this lecture in Illinois, this is already a part of our Illinois Perinatal HIV Prevention Act and is mandatory. But even outside of Illinois, it is highly recommended that if in a high prevalence area, that rapid HIV testing be considered for people who do not have a known HIV status in order to be able to carry out some of the intrapartum measures that I'll speak about next. Moving on to those who have known HIV status, let's speak about some of the landmark trials. Pediatric AIDS Clinical Trials Group, or PACTG, Trial 076, was the one in which it was established that intrapartum IV zidovudine led to a 66% reduction in risk for transmission. Efficacy was observed in all study groups, and the zidovudine dose, which you can see here, is the one we still use now, which is 2 mg per kg of body weight over 1 hour, followed by a continuous infusion of 1 mg per kg of body weight per hour until cord clamp or delivery of the infant. Subsequent studies have demonstrated that partial zidovudine regimens are still beneficial. For example, no treatment here in this New York cohort study led to a 26% risk of transmission versus intrapartum and neonatal treatment only a 10% risk of transmission versus transmission with a complete regimen of the complete regimen meaning oral zidovudine and intrapartum zidovudine led to a 6% transmission. Obviously, we've come a long way since then with transmission rates far less than 1%, but I think it's important to emphasize that even with partial treatment alone, meaning only intrapartum zidovudine and neonatal treatment, there is still an opportunity for prevention of transmission. But what about zidovudine in the era of combination antiretroviral therapy? The French perinatal cohort gave us these data, which showed that among individuals with a viral load less than 400 copies per milliliter at the time of or close to delivery, that there was actually a 0% risk of transmission of HIV among those who had no IV zidovudine. In contrast, most of the perinatal transmissions occurred with those who received who had viral loads greater than 1,000 copies per milliliter in both the no IV zidovudine group and the IV zidovudine group, although the transmission risk was lower in the IV zidovudine group. This study led to a change in recommendations, and that IV zidovudine was no longer required for those who had a viral load that was undetectable at the time of transmission. But I think there are a few key factors about the study that make it potentially challenging to generalize to our United States context. One is that 0% is hard to prove. There were 0 cases of transmission in IV zidovudine group, and yet any result with a confidence interval of 0 is statistically improbable and raises concern for potential bias and lack of generalizability to other contexts. 2 is that there wasn't stratification by parity. And we know that the people who were less likely to receive IV zidovudine were also those who were most likely to be laboring quickly and may have been multiparous and not receiving IV zidovudine because of a shorter length of labor. So I think it's important to consider some potential reasons why this French perinatal cohort study may not be exactly applicable to our setting, and think about that as we move forward to the next few slides. French perinatal cohort also gave us information about the timing of initiation of maternal antiretroviral therapy and found that among individuals who had preconception or periconception timing of antiretroviral therapy, that the risk of transmission was very low or 0 compared to those who had second or third trimester timing of antiretroviral initiation. All in all, this gives us important data that the risk of transmission is exceedingly low for people who present to pregnancy with pre or periconception antiretroviral therapy initiation and who maintain a viral load of undetectable throughout pregnancy, including at the time of birth. I think these should be very reassuring data to the vast majority of our patients. This led to the current guidelines about antiretroviral therapy management during labor and delivery. And you can see here a table from the perinatal guidelines which demonstrates some of the latest recommendations. I want to draw your attention to the second bar about intrapartum IV zidovudine. Currently, our US DHHS perinatal guidelines suggest that IV zidovudine is not required for those with undetectable viral load and no concerns about adherence at the time of labor and delivery, but may be considered for those who have viral loads between 50 and 1,000 copies per milliliter. At Northwestern and with the perinatal hotline in Illinois, we still recommend zidovudine be used, as we consider this an important element of pre-exposure prophylaxis for neonates, and that as long as infants are receiving post-exposure prophylaxis, we have enough concern to continue giving zidovudine, which has very low risk in the intrapartum setting. I also wish to note that there are important data from outside from observational studies, which have suggested that as high as 6 to 7% of individuals will have a viral load blip at the end of pregnancy between their last clinic viral load and labor and delivery, which suggests that we can't always know that somebody remains undetectable at the time of presentation for labor. Other guidelines that you can see here we'll discuss over the next few slides, and I highly recommend going back to this table as a reference for understanding the care of pregnant people with HIV in the intrapartum setting. Let's briefly discuss route of delivery. So cesarean delivery is recommended prior to labor onset, occurring at 38 weeks of gestation for people with an HIV RNA level greater than 1,000 copies per milliliter, or for people with an unknown HIV level. In other words, people who are diagnosed at the time of presentation. Some of the data you can on this recommendation are seen here in the table, where you can see that those who undergo cesarean delivery had a lower risk of perinatal HIV transmission when the viral load was elevated. On the other hand, the benefits of cesarean delivery after rupture of membranes or onset of labor are unclear, and the perinatal guidelines recommend that management of patients who present with ruptured membranes or in labor who had otherwise been planned to have a scheduled cesarean delivery for because of an HIV viral load be individualized based on things like timing of labor, dilation, or timing of rupture of membranes, membrane dilation at the time, and viral load. These are all situations in which we would recommend calling the hotline for further guidance. For those who are undergoing labor, there's a few important considerations. As you saw on the earlier slide, induction of labor and oxytocin use can be used per standard obstetric guidelines, but we recommend, and the guidelines recommend, avoiding a fetal scalp electrode in almost all circumstances. However, standard obstetric indications can be used, but avoiding in the setting of viremia for interventions such as an intrauterine pressure catheter, artificial rupture of membranes, and forceps or vacuum. In other words, individuals for whom these are necessary for obstetric indications such as safety or expediting labor, these may be considered, but we should be highly cautious about using any of these interventions in anyone who has concern for potential viremia. Importantly, it is essential to expedite labor once rupture of membrane has occurred, since there are data that prolonged rupture of membranes is associated with perinatal transmission. And then in terms of managing postpartum hemorrhage, it's important to remember that there are protease inhibitor interactions with methergin between both PIs and cobicistat, which are CYP3A4 inhibitors. And these should only be used if there are no alternatives for postpartum hemorrhage available and the needs for pharmacologic treatment outweigh the risks. There are a few other labor considerations I just want to call your attention to. These include that delayed cord clamping can be done per usual standard of care. There are no data to guide this in perinatal HIV scenarios. It's important to consider confidentiality and that many of our patients will present to labor and delivery with family members who may not be aware of their HIV status. And it's important for all team members, including nursing, OBGYNs, midwives, and nursing and postpartum care team members, such as the neonatal providers, all be aware of the importance of confidentiality. We still want to encourage maternal-infant bonding, although the infant needs an early bath in order to have all maternal blood and secretions removed prior to injections. This can be done on the maternal chest. We want to ensure good communication between OB and pediatricians in order to make sure that the neonate is receiving all of the medications that are indicated. And then finally, we want to provide routine antiretroviral therapy during labor. It's important that we not forget to order the antepartum ART regimen on admission, particularly for patients who may be undergoing a induction of labor that crosses over a 24-hour period. I want to thank you for your attention and also point you to the perinatal guidelines for any further information on these topics. Thank you.